Good afternoon. I'm Damiano Regazzoli from Italy, Milan. I worked for a lot of years, since 2010, with Professor Antonio Colombo. So I have to admit that I have some conflict of interest because I was a super fan since the beginning of BRS. I implanted a lot of Absorb and a lot of Dissolve too. And then I went back to stents, obviously, as anyone. And then now we are working a lot with DCBs and with bioadapters because we really believe in the technology. So I'm here to present a couple of data from our study. That is the Dynamite study, and also to show you a couple of cases from a sub-study that we are going to present sooner or later in the next year, and it's gonna be pretty interesting in our opinion. So I don't want to spend too much time on the background because we already discussed the background here together. So we know it's this slide. I think that is one of the most used slide. When talking about long-term result of stents. We know that after the first year we have this problem of an attrition of events that is probably related to the vessel caging and the reduced vasomotion and the induced shear stress on vessel walls. So to be honest, we need to do something more here. And at the time, we really believed that Dissolve and Absorb would have been the answer. Now we really don't know, but we are searching for an answer, and an answer may be the Dynamics Bioadaptor that we are using a lot in Milan. We already know, and we already discussed about the structure of the stent itself, that is metallic, but also has links that are reabsorbable, and it leads to an partial uncaging of the vessel after the reabsorption process that takes the first 6 months. So what is the hypothesis that drove us or took us to take this to do this study? So in fact, we really believe that metallic stents does not allow positive remodeling over time, because we know that the drugs that we bring down into the artery somehow will generate positive remodeling. It's also the concept of DCB or the whole concept of drug eluting something, stents, BRS, balloons, and whatever. But the caging of the vessel does not allow to obtain a good positive remodeling. The hypothesis was that Dynamics was able to allow this positive remodeling because of the potential or at least partial uncaging of the vessel after reabsorption of the links. So we designed this study. This is called the Dynamite study. The PI was Antonio Colombo. It was observational, not a randomized trial, and it was not intended to evaluate clinical events. Where we did OCT at the baseline after Bioadaptor implantation and at 9-month follow-up, and all the patients were treated only with complex coronary artery disease. They were all chronic coronary syndrome, and the inclusion criteria was to implant the Bioadaptor in long lesion, defined as more than 38 millimeter, when the patient could have been enrolled when we implanted 4 or more devices, where we treated a CTO or a big bifurcation with a side branch more than 2.5 millimeters, so a real bifurcation, let's call it like that. So the endpoints that we decided to evaluate were not clinical, once again, were mainly related to OCT results. So it took us a little bit of an effort, because OCT is something that must be accepted also for the patient, because it's not a standard follow-up. But anyway, at the end of the day, we were able to enroll 55 patients. The population is pretty standard, with 30% more or less of diabetic patients, and mainly with chronic coronary syndrome. One of them had unstable angina, only a few of them with some troponin release. So, in fact, it was mainly a stable population with complex coronary artery disease. This is the procedural, so the lesion characteristic. Obviously, you can see that we used the vast majority, we enrolled the vast majority of patients treated on the LAD, 50 or more % of the patients, and 40% of them were treated on the RCA. The lesion complexity was B2 or C, but it was an inclusion criteria, so for sure it was mandatory. But look at that, CTO almost 25%, calcification that was not an inclusion criteria, but anyway was really present in this population, more than 60%, and bifurcation 16%. So it means that the highest inclusion criteria, the highest used inclusion criteria was long lesion. So PCI was carried on pretty standard, with a good pre-dilatation, stent implantation or Bioadaptor implantation, but also a good lesion preparation when needed, with cutting, balloons, rotational atherectomy, orbital atherectomy. At the time, IVL was not so widespread like it is right now, so we use not a lot of it. But anyway, we implanted usually pretty long device length, and we post-dilated it routinely up to 0.5 millimeter over the nominal size of the bioadapter. That is the threshold, because it's a little bit fragile in the first phase or during the implantation. So what we did was evaluate the OCT at the end of the procedure. Obviously, we also did the OCT at the baseline before doing the PCI, but it's not something that is included in the study. So we did OCT after the procedure, so after bioadapter implantation, and we reevaluated the same segment at 9 months. Only 5 patients did not come, so we have a lot of data about patients. So I put here OCT data, but first I want to show you clinical data, because we knew that 55 patients was really a low number for evaluating clinical events. Anyway, at 9 months, only 4 patients received or suffered from a target lesion revascularization, and to be honest, all the target lesion revascularization were linked to the angiographic control. So no patient was symptomatic at the time of the angiographic control. So to be honest, clinical events were really low, in line with the study that we already discussed, like the Infinity. So let's go to the OCT data. These are the OCT data. So what is pretty clear is that device area, that is defined as the area inside the device. We had an independent core lab by Professor Prati doing the analysis, increased over time. So it's something that matches our hypothesis, our physiopathological hypothesis. So device area increases over time, borderline significantly, but anyway increases over time, with a gain of 5.5 square percent in terms of area. On the other hand, intra-device tissue area was more or less 1 square millimeter. That is exactly in line with all the other studies that use the OCT for evaluation of follow-up of this population. Just keep in mind that our population was a complex coronary artery disease population, not a standard population or an easy one. So you can see here that our results are more or less in line with the Bioadaptor RCT, and it's for sure better than other studies that followed up patients with complex coronary artery disease after stent implantation. So what does it mean? It means that the stent is getting bigger, and it's getting bigger because the vessel is getting bigger. On the other hand, obviously, you have some tissue inside the stent, so the stent, the bioadaptor, to be precise, and the tissue is there and is there and is there in every metallic object that we are placing inside the arteries. It will be there. So it's not a big deal, because the ratio between what we gain and what we lose after implanting the bioadaptor is in favor of what we gain. And this is probably what we are seeing in clinical studies. I wanted to show you just a couple of examples. This was not a super complex CTO, but still a CTO of the RCA. We crossed it pretty easily. We pre-dilated and implanted a 3/38 post-dilated with 3.25 non-compliant. And also we did a kissing. That is something that in the acute phase may be a little bit dangerous for the links, but it's not. To be honest, or at least not in our experience. And this is the OCT performed after the just after the procedure and at the follow-up. And you can see here that the numbers are there, pretty small anyway, but you can see here that we add some positive remodeling all along, on the wall artery. For sure, it's something that on the CTO setting can happen more frequently, because we know the CTO vessels are really negatively remodeled by the CTO itself. But anyway, the device area increased in the 9 months that we evaluated the patient. Another case, this one, and this is the typical case that we discussed in the previous presentation, is a long LAD lesion, the one that can be treated with the Lima, that is still the gold standard, and now we are starting treating this type of patient with an hybrid approach, metallic drug-coated balloon. We treated it with BVS, but in this case we treated the patient with bioadaptor. It's a long lesion, 28 plus 18 plus 23. So we are talking about almost 70 millimeter of device inside the LAD. The final result was fine, but look at the follow-up OCT. So in fact, it's not exactly the same frame, but anyway, it's really near. You can see that the vessel had remodeled positively, and the vessel and the lumen growth over time. So I wanted to show the vasomotion. So let me tell it you straight, because this is not the final deck, but it's not a big deal. We also evaluated 15 patients at the follow-up with a vasomotion sub-study, where we gave them acetylcholine and nitrates. So we did OCT at the follow-up, after giving acetylcholine, after giving nitrates, and we reported a variation between the OCT vessel and the device area up to 10% negative in terms of acetylcholine, and positive in terms of nitrates. So it means that probably the caging is not there anymore at 9 months, and the vessel is positively remodeling. So to me, this is pretty clear as an explanation, because we now have a device that is meant to be a scaffolding system in the acute phase, but a de-scaffolding system in the subacute phase, in order to reduce late events. And to me, these data that we already discussed also in the previous presentation are something that deserves more attention in the interventional cardiology community. Thank you very much.